The following podcast is part of a certified educational activity titled Real World, Real Innovation in DLBCL, Perspectives on Integrating Novel Antibody Platforms into Patient Care. Access the entire activity and complete the post-test at peerview.com/ENP860. Downloadable slides and practice aids are also available.
Good morning. Welcome everybody to Real World, Real Innovation in Diffuse Large B-cell Lymphoma Symposium, focus on perspective on integrating novel antibody platforms into patient care in diffuse large B-cell lymphoma. My name is Greg Nowakowski. I'm from Mayo Clinic, Rochester, and I'm fortunate to be joined here today by two excellent lymphoma investigators, Dr. Paulo Kaimi from Cleveland Clinic and Dr. Steven Schuster from University of Pennsylvania. So we'll start with a short introduction to diffuse large B-cell lymphoma. And as you all know, this is a very exciting time in diffuse large B-cell lymphoma where many new agents and cellular therapies are being rapidly introduced to patient care throughout the lines of therapy. As a reminder, diffuse large B-cell lymphoma is the most common non-Hodgkin's lymphoma in US and worldwide, accounting for about 30 to 40% of all non-Hodgkin's lymphomas. This accounts to approximately 18,000 cases diagnosed annually in the United States. This malignancy has typically aggressive course with rapidly enlarging lymphadenopathy and compressive symptoms resulting from it, and frequently constitutional symptoms are present at diagnosis. If you look at the data overall, the survival rate at 5 years for this malignancy is about 65%. Now, for over 20 years now, the standard therapy for frontline diffuse large B-cell lymphoma has been R-CHOP, and this is based on this randomized study which showed that addition of rituximab to CHOP chemotherapy improved both progression-free and overall survival. So it was really the antibody which changed the standard therapy of diffuse large B-cell lymphoma prior to introduction of the novel antibodies now. The other thing which was worth noticing from this curve that in this disease, relapses happen early. If you see there's this early drop-off within the first year or two, and that's typical for diffuse large B-cell lymphoma. Relapses beyond 2 years are quite unusual. And what you can also see that the shape of the overall survival curves mimic the shape of the event-free survival or progression-free survival curves, which said that historically in the past, our therapies for salvage therapy for diffuse large B-cell lymphoma had relatively little impact on overall survival of patients with relapsed disease. Now, adding rituximab to R-CHOP was a huge advance in the field, but we all feel that this therapy is insufficient for many reasons. Number one, a number of patients relapse and relapse early. And there are specific subtypes of the patients who are at particularly high risk of relapse. Those will be patients with double-hit lymphoma, and for that reason, or triple-hit lymphoma, and for that reason, those patients are frequently treated with dose-escalated therapies. There's a lot of discussion about different molecular subtypes of diffuse large B-cell lymphoma. This didn't necessarily translate to routine clinical practice, but we do worry more about patients with ABC or non-GCB subtype of diffuse large B-cell lymphoma as being the ones who are more likely to relapse at the higher risk of CNS relapse as well. And this is just a scholar study which looked at the outcome of patients with refractory and relapsed diffuse large B-cell lymphoma after initial therapy or salvage therapy or autologous stem cell transplant. And you can see here that the median overall survival historically in this group had been quite poor, about 6.3 months. This has led to a lot of interest in developing of new therapies in relapsed refractory diffuse large B-cell lymphoma. And part of those therapies are those novel antibodies, but also cellular therapies are rapidly changing the therapy of relapsed refractory diffuse large B-cell lymphoma. And here is just a perspective from what's already there, approved for the use. So we have 3 antibody drug conjugate or antibody in combination. So this would be Longcasticrin, TafasitoMap, which targets C19 and is approved currently in treatment of a third-line relapsed refractory diffuse large B-cell lymphoma. You have POLA-BR vedotin combined with bendamustine rituxan, which targets CD79B, again, used in the third line, occasionally a second line as well. And TafasitoMap plus Analidomite is an anti-CD19 naked antibody combined with Analidomite, which shows significant efficacy in the second and third line, and it's approved in both. We also have 3 CAR T-cell products listed here. And you can see 2 of those are now moved to the second line therapy, and all of those are available in third line. So where would those novel antibodies and cellular therapy fit into this treatment paradigm of diffuse large B-cell lymphoma? So currently, again, the standard therapy for most of the patients is R-CHOP. Some of the patients with double and triple hit, as already said, will be considered for dose-escalated therapy like dose-adjusted TPOC-R or Codoxem-IVAC. And there is sort of attempts in adding those new antibodies to frontline therapy and improved outcomes there. In relapsed refractory in second line, there's sort of interest in adding the antibodies to therapy, salvage therapy as well. In general, those patients would follow 2 care patterns. The fit patients would be considered for CAR T cells if they had an early relapse after chemoimmunotherapy, or high-dose chemotherapy or stem cell transplantation, which has been traditionally used in this space. Patients who are not fit can be considered now outside of the clinical trial for those approved antibodies, which I mentioned. So today we'll discuss how those novel antibodies work and what are the new developments in upfront setting, how we try to move to the upfront setting. We'll then discuss the evidence leading to the antibody resurgence in relapsed refractory diffuse large B-cell lymphoma, particularly targeting CD19 and CD20, CD3 bispecific antibodies. There's been a huge development there, as you probably are aware. And then we'll have very interesting case discussions, probably on one of the most controversial and interesting topic, how to sequence those therapy, and it will be led by Dr. Schuster. And at the end, we'll take questions and answer session. So we'll start with the overview of the antibodies and then briefly touch on their use in the frontline setting. So really, development of those novel antibodies was possible because of our understanding of biology of malignant B cells and the surface molecules which are possible to be targeted by those antibodies. And we took several different developmental pathways. On this diagram here, you can see various targets. So CD19 is a target which is expressed on the majority of B cells and can be successfully targeted. It is targeted by cellular therapies, which we just mentioned, but also by Longcasticrin, Prescribing, and TafasitoMap. The CD79B is a target of polatuzumab vedotin. Again, it's present on B-cell malignancies. ROR1 is a very promising target, which is currently under investigation with the antibody-drug conjugate. CD30 targeting has been developed a while ago with brentuximab vedotin. It is a very successful therapy in T-cell lymphoma and Hodgkin's lymphoma, and it's still being explored in large cell lymphoma tumors which express CD30. Then you have a traditional target of CD20. This is the first target targeted by antibodies in this lymphoma with rituximab. And more recently, this target showed very nice results with bispecific antibodies, which link the effector cell to CD20 by combining targeting of CD3 and CD20, and there are many more molecules there in development as well. There are also a number of strategies in development which are trying to target immune response molecules. PD-1 checkpoint inhibitors did not necessarily show significant activity as a single agents in non-Hodgkin's lymphoma for the most. However, there's still a lot of interest in investigation of those agents combined with other therapies, including inhibitors of TIM3 and CD137. You can also target other cells in microenvironment, and SIRP-alpha or do not eat me signal inhibitors are being in development as well. And this is building on this premise that we can actually activate immune response and macrophage response against the tumor. So let's look closer on a couple of those, and this will be just examples how they work. And we'll start from TafasitoMap, which is a naked Fc-enhanced anti-CD19 antibody. So this antibody was really engineered to have increased affinity to CD19, increased ADCC and ADCP. And by this increased activity binding to CD19, it actually does show in preclinical studies also a better induction of direct cell death. You can see that the effector cells in the mechanism of action are natural killer cells, as well as macrophages through the Fc receptors. Now, the antibody by itself showed about 25 to 30% response rate, but what really made this therapy stand out is a combination with lenalidomide. And a lot of you who are familiar with the IMiDs know that the IMiDs tend to synergize by working on immune environment with the antibodies. This is certainly true about combination of rituximab with lenalidomide, known as R2. And here we see a combination of analidomide with tafasitamab, which really dramatically increased response rate and durability of responses in diffuse large B-cell lymphoma. Another example of developed antibody is Longcasticrin tessitura. Here, this is the antibody-drug conjugate. Again, there are many more in development, and platuzumab vedotin is already used as well. The concept here is that the antibody has a payload of the active substance. In case of Longcasticrin, this is tessitura, which is the DNA cross-linking agent. And when the antibody binds to the tumor, it gets internalized, and then the drug gets released within the cells, causing the cell death. So this is a magic bullet of chemotherapy delivered directly to the cells. And certainly those antibody-drug conjugates were shown to be a very promising way of developing targeted therapy in diffuse large B-cell lymphoma and other malignancies as well. Finally, we have a number of bispecific antibodies in development. None of those are approved yet by FDA in US, but a lot of us believe that those therapies are coming to the clinic relatively quickly. And here again, the concept is that you're bringing effector cell, typically T cell, by binding to the antibody binding to CD3 receptor on T cells, to target cells, malignant B cell, by binding to CD20. There are other antibodies in development as well, targeting different surface molecules on B cells. Here you have example of Mosun, which is being developed in diffuse large B-cell lymphoma and other B-cell non-Hodgkin's lymphomas. Another example of a bispecific antibody is epcoritamab, which is, again, bispecific antibody against CD3 receptor and CD20, so very similar mechanism of action. It is developed specifically to have those high potency at the lower doses in presence of partial CD20 therapy. So it's really engineering of the therapy which uses the immune system to attack tumor directly and is available off-shelf in contrast to some of the cellular therapies. So how does it affect our current therapies in diffuse large B-cell lymphoma? We already discussed that chemoimmunotherapy remains standard in the frontline setting, and one of the antibody-drug conjugate could be moving there. We'll talk about this in a minute. In patients with poor ejection fraction, in lymphoma with cardiomyopathy, we can use other chemotherapies, which are typically replacing doxycycline with other agents. And the very challenging population to treat are very frail patients, 80 and older with frequent comorbidities. And traditionally, we've been using chemoimmunotherapy in this setting, often with modest results. Some of those patients could not tolerate actually chemotherapy. And there are some exciting developments moving antibodies to the first-line therapy as well. It is worth mentioning that lenalidomide actually was studied as a maintenance after chemoimmunotherapy by our colleagues from France. And this has shown actually improvement in progression-free survival after chemoimmunotherapy. In terms of the second-line recommendations, with the intent to treatment, which will be typically relapse more than a year after chemoimmunotherapy, we typically would salvage those patients with intensive chemotherapy, followed by high-dose chemotherapy oligo stem cell transplantation. You can see some of the chemotherapy choices here. For patients which we consider to have refractory disease, which be relapse within 12 months, the treatment with CAR T-cell therapy, both with axi-cell and liso-cell, became a standard in this setting based on the data from randomized studies. There's a huge unmet need of the effective bridging therapy. That's something which Dr. Schuster frequently highlights in his talk, how we effectively treat the patients to stabilize their tumor, which is often rapidly progressive before treatment with CAR T-cells, and there are some options which you see listed here as well. And patients who are not transplant candidates are still candidates for typical salvage chemotherapy, usually gemcitabine or platinum-based, as well as combination of TafasitoMap and Analidomite and POLA-BR. Allogeneic stem cell transplantation can be used in selective patients. I must say, nowadays with the CAR T-cell therapy, I cannot remember when was the last time I referred somebody for allogeneic stem cell transplantation. And all the agents which I mentioned are available in the third-line setting as well, including for the patients who relapse after CAR T-cell therapy, which is still a significant problem. Which brings us to this current landscape. Again, after chemotherapy, if you're transplant eligible and fit, you'd be considered for transplant if you have this late relapse versus CAR T-cell therapy if it's late relapse, and those antibody and other agents which you have shown in those boxes are available for those patients as well. So really we see very rapid evolution of therapy of diffuse large B-cell lymphoma in the last couple of years. So is there a role for bringing some of those agents to frontline therapy of diffuse large B-cell lymphoma? And we will focus on update on the POLARIX study and how addition of polatuzumab vedotin affects the activity of chemoimmunotherapy in frontline setting. I will briefly discuss Frontline study, which is currently ongoing, which is a very interesting design, and then discuss some of the other abstracts here at ASH, which are trying to use different strategy of treatment in frontline setting. So this is design of the POLARIX study. So POLARIX study randomized adult patients with IPI 2 to 5, so kind of higher risk patients, to two arms. One was polatuzumab vedotin given at the dose and schedule shown here in combination with RCHP. RCHP is chopped without vincristine, and the reason for this is that vincristine could be, in addition to polatuzumab vedotin, could be inducing neuropathy. And this was compared to standard therapy with R-CHOP, and you can see the endpoint the primary endpoint in the study was progression-free survival, which is typically a standard endpoint in this setting. And those are the high-level results. You can see that addition of polatuzumab vedotin to frontline chemoimmunotherapy resulted in improvement in progression-free survival. If you look at those curves, there are two interesting observations. Number one, the separation occurs relatively late, which for me tells me that maybe there is less impact on primary refractory disease, but this benefit in progression-free survival appears to be occurring later on. The other interesting finding, looking at the overall survival curve, is that you do not see a difference in overall survival, and overall the outcomes are actually excellent for the patients on the study, which is something which we see across studies in diffuse large B-cell lymphoma in a frontline setting for different reasons, including patient selection for performance status and the tempo of the disease. Patients who do enter clinical studies do better than historical controls in diffuse large B-cell lymphoma, and we also see it in this study. Now, if you look at the absolute risk reduction, it is relatively small. But if you look at the relative risk reduction, it corresponds to about 27% risk reduction of progression or death. So it's quite a significant gain in control of the disease with polatuzumab vedotin. So what's the cost of this therapy in terms of the toxicity? You can see that the toxicity actually in both arms was very similar. There was a slightly higher incidence of neutropenia, as you would expect it, with a higher intensity therapy. Peripheral neuropathy, which a lot of people worried about, was actually not significantly different. And overall, the side effect profile was very similar. There was also quality of life performed in the study, and it will be presented at this year ASH by Jonathan Friedberg. And just the big picture of those results really showed no difference in the symptom score between the patients receiving therapy in both arms, which is consistent with this very similar toxicity profile of both arms as well. You can also see that the patient perception of their condition is improving over time, which we typically see in those malignancies which are responsive to therapy. Now, another attempt to improve on R-CHOP therapy was addition of lenalidomide to R-CHOP, and there were actually two studies. One study called Robust, which I'm not showing you here, which actually showed no benefit in terms of the progression-free survival. The other one was a randomized phase 2 study called E1412, conducted by US intergroup with ECOG leadership. And in this study, there was some signal that possibly addition of lenalidomide could be improving on R-CHOP. And this data, along with the data of lenalidomide with TafasitoMap in relapsed refractory setting, led to design of frontline studies of this doublet of the antibody and the lenalidomide in a frontline setting. So these are results from the first MIND study. The update of the study we presented at this meeting as well. And in the study, R-CHOP was combined with TafasitoMap or TafasitoMap plus lenalidomide, so R-squared CHOP backbone plus TafasitoMap. And the important finding in the study was that this combination was feasible, and there was an increased hematological toxicity, as we'd expect with lenalidomide, but there was really no increase in neutropenia, and patients were able to complete this therapy. Those early results led to development of currently ongoing Frontline study, which is a large randomized phase 3 study in patients with newly diagnosed diffuse large B-cell lymphoma. And you can see study design here. So what's a couple of interesting aspects of the design. First, the study focuses on high-risk patients, so IPI 3 to 5. The other interesting thing is that we had shown in the past that patients who could wait a long time before starting chemotherapy because they had relatively little symptoms and slowly progressive disease had significantly better outcome than patients with rapidly progressive disease. That's typical how life goes. If you have a patient coming on Friday night with rapidly progressive adenopathy, they go to the hospital and they frequently don't go on the clinical studies. And then patients who can sometimes wait for weeks or even months are the ones who frequently enter clinical study. And as you've seen in an example from the POLA-BR study, it does appear to be affecting the outcome of the studies that the control arm is actually overperforming. So what was being done in this study, what we are doing in this study, is actually we require the diagnosis to treatment interval is no more than 28 days. And to my knowledge, this is the first study which is really trying to capture those rapid progressors early on and capture them in the study. Those patients that are randomized to R-squared CHOP backbone, just like in E1412 plus TafasitoMap versus R-CHOP and placebo. And the endpoint, just like in other studies, the progression-free survival. The study is ongoing and hopefully will be completed next year. So outside of adding those novel agents to chemotherapy backbone, are there any other ways of developing frontline therapies? There are a number of patients, which we mentioned at the beginning, which are unfit or frail, and they cannot really be treated with chemoimmunotherapy or just decline chemotherapy up front because of fear of potential side effects, because of this frailty and comorbidities. And here we have LOTIS-9 study, which has a very interesting design of combination of LONCA with rituximab in previously untreated diffuse large B-cell lymphoma. And you can see here there are 2 cohorts of patients. It's a relatively small study targeting 40 patients per arm. One cohort is just focused on unfit patients over 80, and the other cohort is focused on patients with cardiac comorbidity as well. The endpoints in this study is actually CR rate, which in diffuse large B-cell lymphoma after therapy is meaningful. And you can see that in the design, the initial treatment plan is for 4 cycles, but if patients are in PR, you can continue to up to 6 cycles of therapy. So it's going to be a very interesting study to observe and see the results, because it's moving away a little bit from this paradigm of using always chemotherapy backbone in a development up front in a patient population who is not really eligible for this therapy. The other strategy to do that, and the update on the study will be presented at this meeting, is trying to one of the bispecific antibodies, which really show very nice results in addition to R-CHOP chemotherapy. And here we have a study of glofitamab added to R-CHOP in a frontline setting. The study is very early on, but the overall response rate of over 90% and very high CR rate is definitely very promising. We'll have to see how the time-dependent endpoints, progression-free survival and overall survival, will look in this study. What's also worth noticing that cytokine release syndrome is relatively rare in this frontline use with chemotherapy, and the grade 3, which is the severe one, is actually was not reported, which again shows feasibility of those bispecific combinations with chemotherapy in frontline setting. The other bispecific antibodies are also being used as a monotherapy in elderly unfit patients. So this is a little bit like the LOTIS-9 concept, which we just discussed, but now looking at the bispecific antibody. And Mosun was studied in this setting, and at this year ASH, we'll see a follow-up abstract reporting extended follow-up on those patients. The initial response rates are about approximately 50% in this study. So would it stand alone, or would it require additional agents to enhance this response rates, and how durable they are will be something which we'll have to watch very closely. So I'll finish with some take-home messages on those novel antibodies and potential to moving to frontline therapy. First, that frontline therapy in diffuse large B-cell lymphoma is still an unmet need. There is still clearly, even with advances of polatuzumab, there's still a lot of room for improvement, particularly for those patients with rapidly progressive disease, double or triple hit lymphoma, and different high-risk molecular subtypes. Polatuzumab vedotin plus RCHP definitely improved progression-free survival. Somewhat surprisingly, this was not followed by improvement in overall survival, but I think it could be explained by this late separation of progression-free survival, and overall very good results in terms of the overall survival for the patients in this study. The combinations of novel antibodies and bispecific antibodies with R-CHOP are very promising, and we'll see a whole wave of early and randomized studies in this setting. And I would urge you to enroll your patients with newly diagnosed diffuse large B-cell lymphoma in those studies. The one which is interesting and ongoing, which we'll probably read fairly soon, is the Frontline design, because it's actually adding doublet on the top of traditional chemotherapy rather than traditional way of adding one agent at a time. So in the past, we used to call it X-R-CHOP. Now we have XY-R-CHOP, if you would. And I think what's also very important about those developments with the therapies, with antibodies and antibody-drug conjugating bispecific antibodies, that so far they appear to be molecular subtype of diffuse large B-cell lymphoma agnostic. So in the relapsed refractory setting, a lot of those responses are seen across molecular subtypes of diffuse large B-cell lymphoma, which I think makes development of those drugs in early therapy much easier. In the past, when we tried to develop some of the molecularly targeted therapies up front, there's always an issue of real-time molecular classification and identification of the patients with different molecular clusters or subtypes. And with those agnostic therapies, this is currently not an issue. It may emerge later on if we find that some of the subtypes are not benefiting from those additional liver therapies, but as of now, the evidence is showing activity broadly across various subtypes. Again, thank you very much for your attention. I'll pass it now to Dr. Kaimi.
Thank you very much. Good morning. So the main thing is whether we can challenge the frontline R-CHOP with the new drugs, with the results of POLARIX, as well as this upcoming results of the addition of Tafalen in frontline to CHOP, and whether the addition of bispecifics can also challenge the standards of frontline therapy. But in addition, whether we can use non-chemotherapy-based regimens for patients who are most frail. The additional area where we're seeing significant changes, I would say, is second line and subsequent therapies. I think we already have CAR-Ts as part of the standard approach, particularly for patients who are refractory or early relapsed after frontline therapy with an anthracycline chemotherapy. But we'll see that as we add new agents, I'm going to have more and more alternatives. I think we're switching again from like a linear-based of approach to where you're going to R-CHOP, second-line therapy, transplant, to having a multitude of different alternatives. You're really using it as a matrix where you're having 2 or 3 alternatives when you start, 2 or 3 alternatives when you have a second line, and more on the third line. So I think this will make our decisions in treatment much more complex, but also much better for patients. And you'll see here, as we talked about, we have multiple anti-CD19 and targeting drugs, multiple new immunotherapies. So what is the evidence supporting the novel antibodies in relapsed refractory diffuse large B-cell lymphoma? And we'll start with L-MIND. L-MIND was a trial of TafasitoMap and Analidomite in patients with refractory or relapsed diffuse large B-cell lymphoma, but were not eligible for stem cell transplant. And they had received 1 to 3 prior lines of therapy. They were either not eligible because of age or comorbidities. It did not include patients with primary refractory disease, and particularly after a specific amendment in terms of time from relapse. The treatment on the single-arm phase 2 trial was TafasitoMap, which was given on the first few cycles on a frequent basis, day 1, 8, 15, and 22 on the first cycle, and then on cycles 1 and 3, continue on that 4 weekly doses, and then from cycles 4 to 12, it was given every 2 weeks, when lenalidomide was given throughout the whole first year as well, from days 1 to 21 of each 4-week cycle. Once the first year, patients who were on stable disease or better continued on to tafasitamab and were treated in an indefinite basis until progression. Primary endpoint for this study was overall response rate, with secondary endpoints of progression-free survival and duration of response, which we'll see was something observed significantly in this trial. And you'll see here that the overall response rate, when we used a pointer trying to go through this kind of complex table, but the overall response rate for the whole group was 57.5%, with 40% complete response rate for the whole group. But also, if you see patients who have 1 prior line of therapy, the complete response rate was close to 50%. The median duration of response, again, for the whole group, 43.9 months at the time of report, with a median progression-free survival of close to a year. You see here the curves showing how the outcomes of patients at 3 years for patients that had a complete response were significantly impressive for a population of patients with relapsed diffuse large B-cell lymphoma. And here again, as you see in the swimmer plot that we're advancing here, there you can see that multiple patients are now more than 4 years out. Some continued in treatment, some even have not continued treatment and continue with disease control. So again, a very active agent for patients with relapsed refractory diffuse large B-cell lymphoma. They suggest that patients can continue in prolonged remission with survivals of 5 years or more. And again, the other important thing is because we're getting 1 year of lenalidomide and then continued on the antibody as a single agent, the adverse events that you'll see will be more concentrated in the first year, and patients, once they continue on monotherapy, can tolerate the treatment much better. It is somewhat complex to give, particularly in the first few months. As we talked already, they have 5 doses on the first few weeks of treatment of TafasitoMap with the lenalidomide on days 1 to 21. On cycles 2 and 3, they also get 4 weekly doses of TafasitoMap continued on lenalidomide, and then they continue on the 2 weekly doses of TafasitoMap. So we'll require for those patients to continue to come on the first few months on a frequent basis. But then once monotherapy is established, they can continue every 2 weeks. In terms of adverse events, we see the hematologic toxicity was a common adverse event in about 50% of patients, as well as, and you'll see that neutropenia and anemia were also in about a third of patients, but high-grade toxicities were not that common except for neutropenia. And probably this was also an effect of the use of the additional lenalidomide. And not very frequent infections, 12% of neutropenia. The incidence and severity of, again, treatment-emergent adverse events was much lower once you moved to monotherapy. So much better tolerated once you're giving the single-agent antibody. Well, Dr. Nowakowski presented last year the comparison of the propensity risk score-based trial, the comparison with the outcomes of patients who received tafasitamab lenalidomide with those who received treatments that are approved either by our NCCN or the ESMO guidelines. And what was interesting from this study was that comparable patients receiving tafasitamab lenalidomide compared with those who received polatuzumab and bendamustine rituximab were significantly better for those who had tafalen. The same when the comparison was between tafalen and R squared, and with comparable progression-free survival for patients who survival for patients who received tafalen and CAR-T. So again, this suggests that tafalen is a very active regimen, although I think here with the propensity scores, so that there's somewhat of a selection of the patients to match them by their risk. Now, can you use it before or after CAR-T? And I think here's a case report. There's some preclinical data that suggests that sequential tafasitamab and CAR-T, that the use of tafasitamab prior to CAR-T does not inhibit the anti-tumor activity of the CAR, but rather promotes it in xenograft models. And there's one case report where this is a patient that received dose-adjusted REBOC, achieved complete remission, then a couple years later received RIs, received 3 cycles, achieved complete remission, then 2 years later had a relapse again, participated in an L-MIND, had tafasitamab lenalidomide times 7 cycles, did not achieve response, but went on to have stable disease, was salvaged again with R-GemOx, probably at the beginning of the following year of treatment, and subsequently was able to receive axi-cel, achieving a complete remission. Now, this patient was able to achieve a complete remission despite having received L-MIND, so you see that having a sequential CD19 agent did not preclude the activity of the CAR-Ts. At the end, this patient developed an acute leukemia. There was no relapse of the lymphoma and died from the myeloid disease. So I think this suggests, at least in one case, that tafasitamab did not affect the activity of the CAR T-cell therapy. And it would be important when you're having to retreat somebody with a CAR T of making sure that there's CD19 expression. And that CD19 expression studied in patients receiving tafasitamab shows that patients achieving different responses to tafasitamab, either progression, partial response, progressive disease, or stable disease, or complete remission, had different levels of CD19 expression, but it was consistently detected by immunohistochemistry. And this suggests that the treatment with tafasitamab does not lead to significant loss of the antigen. And there, you can continue to be treated with CD19 drugs. Now, the practical summary for tafasitamab lenalidomide and the take-home points was certainly an option for patients who are transplant ineligible, who have relapsed after the initial therapy for diffuse large B-cell lymphoma. I think it's probably very important, as we'll see, there's an abstract presented by Dr. Qualls from Memorial, who is showing how patients who have relapsed within first line can have very good responses, And this is in a real-world analysis, and also showing that patients who have been treated with CAR-Ts also can have responses with Tafalen. The scheduling for Tafalen is somewhat complex. It should be considered in patients who are relatively frail and cannot get participate in transplant. It requires this frequent visit for the first 2 months, and you continue on the TafasitoMap beyond the 12 months indefinitely. The safety profile with initial hematologic toxicity definitely eases off after the second year, and the responders have a real chance of having long-term disease control. Moving on to Longcasticrin, the LOTIS-2 trial studied Longcasticrin in relapsed refractory diffuse large B-cell lymphoma after 2 or more lines of therapy. Longcasticrin, as we saw, is an antibody-drug immunoconjugate. It's given on a different basis. You actually get two loading doses separated over 3 weeks, and then you continue at half dose of 75 micrograms per kilo beyond 2 cycles. And the treatment is up for up to a year. On the trial, the follow-up continued every 12 weeks up to 3 years, but there was no treatment on the trial. This trial included 145 patients with relapsed refractory diffuse large B with more than 2 lines of therapy, 2 or more. The overall response rate, as you see in the overall population, was 48%, and the median duration of response was 10.25 months and about 13 months for patients in complete remission. And you see here that for the whole population, the response was 48%, and it wasn't really that different in terms of overall response for those of different risk. This was a very small group of high-grade B-cell lymphoma with double hit. The overall response rate was the same, and it happened that all of them had complete remission, but I think it's probably similar to that of all diffuse large B-cell lymphoma. Again, we said 48% overall response, the median duration, and the complete remission of about 24%. And again, the longer follow-up after about 18 months, we saw the median duration response was 13.7 months. And here you see this is the analysis of high-risk populations, and in general, the statistics either was not statistically significantly different, though the outcomes were double or triple hit, those of advanced age, patients who had refractory disease to frontline therapy, or those who had transformed lymphoma versus de novo diffuse large B-cell lymphoma. So in general, again, subtype agnostic, risk agnostic. This trial included patients of all risk groups, so intended to have responses that were comparable among all the disease groups. Also, you see here the progression-free survival, always better for those who had complete remission, with the duration of response for responders of about 13 months that we saw earlier. And compared with again, not comparing trial, but in terms of looking at progression-free survival, this is a high-risk population with more heavily pretreated than we see in Tafalen, and also included refractory patients. Now, it's safe, but it has certain adverse events that have to be noted. It has some hematologic toxicity. Thrombocytopenia was not as frequent. Remarkably, there's a few patients that develop gamma-glutamyl transferase increases without increases in transaminases or subsequent liver damage, but it's something that needs to be monitored. Patients were on the trial were discontinued because of GDT increases, but we haven't seen significant liver toxicity. There's other safety events that need to be observed, particularly the fluid retention and edema. Patients need to be weighed frequently, and the risk of photosensitivity with this drug. 57% and 39% of patients had serious adverse events. The rate of discontinuation, though, was comparable to those discontinuation rates in TafasitoMap, Analidomite, and in polatuzumab, bendamustine, rituximab. LOTIS-3 it's a study that is ongoing that is looking at a combination of Longcasticrin with ibrutinib. It's done in diffuse large B-cell lymphoma in both in germinal-centered and non-germinal-centered diffuse large B-cell lymphoma. The treatment schedule is somewhat different because ibrutinib is continuous, but Longcasticrin is given 2 cycles on, then 2 cycles off, and then 2 cycles on. So the patients have an intermittent treatment with Longcasticrin, and the overall response was close to 60%, but 77% in germinal center diffuse large B-cell lymphoma, although with very small numbers. And the protocol is being amended to be able to do continuous Longcasticrin because the tolerability allowed, at least on this trial. So they're looking at whether continuous treatment can lead to better responses. LOTIS-5, we'll see next, is a trial that is planned, that is already on the safety phase. It's enrolling patients. It's comparing Longcasticrin combined with rituximab versus R-GemOx, a salvage for patients who have relapsed or refractory diffuse large B-cell lymphoma. The dosing is similar, again, 150 times 2 cycles, and then 75 continued up to 6 additional cycles. And patients are going to continue to be followed after end of treatment for up to, I think, 4 years. And this trial is enrolling actively, and it's already going to come out of its safety phase for Longcasticrin-rituximab combination. Now, when you prescribe LONCA, there's certain considerations to avoid excessive fluid retention. Premedication with steroids helps. We do it at day -1, 1, and 2 with dose of dexamethasone, giving them orally at home, and then for the day off and day after. If the patient skips the dose on day -1, you can give it IV. You have to monitor their GGT. We don't really know, again, the clinical significance. Definitely monitoring the edema and effusions. Patients have pleural effusions, ascites. I've seen facial fluid retention, and the use of diuretics can help, but it's not always consistent. And in general, the combination of spironolactone and loop diuretics are something that it's worked best. Photosensitivity is definitely an issue. It's both to UVA and UVB, so patients can get sunburns through glass. You have to be monitoring the patients, and you usually recommend patients to cover themselves, stay in the shade, and use sunblock as much as they can. And there is a long-term rash that can happen that is independent to the photosensitivity. Those are things to consider, particularly with patients' occupations, or some patients really like to be in the sun, for whom this may not be an ideal drug. In general, though, it can be prevented with avoidance of direct sun exposure. Now, moving on to bispecifics. This is an exciting new class of drugs that is upcoming. We'll start here with the presentation by Dr. Schuster from a couple of years ago, the plenary session at ASH, showing the activity of mosunetuzumab in relapsed refractory lymphomas. It included aggressive non-Hodgkin lymphoma, and these are patients that were heavily pretreated. And you see there's a large phase 1 study that included more than 100 aggressive non-Hodgkin lymphoma, with response rates, again, with a heavily pretreated high-risk patient population of a complete response rate of 20% and overall response of 37.8%. But a significant proportion of patients were refractory to prior therapy, including rituximab or transplant. Again, achieving complete responses and suggesting already that this class of drugs is active for treatment of aggressive lymphomas. And you see here the swimmer plot showing many patients continuing on treatment at the time of report. The updated results of the trial that were published earlier this year with Dr. Bade as first author showed that the overall response rate was 34.9%, complete response rate, again, close to 20%, with significant tolerability when there's a step-up dosing. We saw cytokine release syndrome can occur with this class of agents, and the step-up dosing allows for a manageable safety profile and allows for patients to stay on the drug. Classically, the toxicity, the CRS happens on the first few cycles. You see the overall response rate, 34.9. The median duration of response, 22.8 months. Again, impressive for this patient population, with, again, about a third of patients having cytokine release syndrome, but mostly low grade, with a very small percentage of patients having grade 3, and mostly confined to the early phases of treatment. Now, glofitamab is another bispecific antibody. It has a different structure. It's a 2-to-1 attachment of CD20 and CD3. This bivalency allows for potential exposure to another anti-CD20 drug, which may help for both tolerability in terms of decreasing CRS, as well as potentially helping with efficacy. The phase 1 study evaluated glofitamab in relapsed refractory non-Hodgkin lymphoma with very good responses across different histologic subtypes, including diffuse large B-cell lymphoma and transformed follicular lymphoma. You'll see here, again, another large phase 1 study, but included 73 diffuse large B-cell lymphoma patients. Overall response rate was a little bit higher than we saw in the previous trial. Again, comparing trials, not necessarily appropriate, but again, 41% overall response rate, complete response rate of 28%. And at the higher doses, you see responses close to 55% for overall response rate and 42%. With the transformed follicular lymphoma, the rates were somewhat higher as well, close to over 60%, and all of them were complete responses. In all cohorts here, you'll see that the complete remission close to 40%, and the overall response rate close to 50%, but the median duration follow-up of 12 months, with responses that happen relatively early in the course of treatment. So again, another monoclonal bispecific antibody showing activity in relapsed refractory non-Hodgkin transformed aggressive lymphoma. And the tolerability seems to be comparable. Again, cytokine release syndrome is common, but it tends to be rarely of high grade, with some hematologic toxicity, and these patients are usually fairly highly pretreated. Cytokine release syndrome, again, usually contained on the first few doses and of grade 1 or 2. And the usually discontinuation related to adverse events is not a common event. In terms of epcoritamab, is this yet another bispecific antibody, has a specific quality that can be administered subcutaneous. It's been studied subcutaneously since conception. This is a study that included 73 patients with relapsed or refractory diffuse large B-cell non-Hodgkin lymphoma that included diffuse large B-cell lymphoma. And you see the overall response rate for the whole population approximately 60%, and the complete responses over 30%, 30 to 40%, and in the higher doses, although very small, close to 100%. And here you see that the adverse events, again, cytokine release syndrome is a common event, but most of them, if not all, of lower grade. Very small numbers of neurological toxicities and tumor lysis syndrome in only a few patients. There's no correlation between the incidence of CRS and the epcoritamab dose, as you can see, and that's also because the earlier dosing, depending on also is affected by the tumor burden. Here's the waterfall plot, and after a median follow-up of 10.7 months, the overall response was 63%, with 39% complete remission, with median progression-free survival of 4.4 months, but again, very short follow-up. And the median PFS for patients in complete remission not reached. So the take-home points for bispecific antibodies, again, this is a very highly anticipated drug class. We're all expecting. I think one of the complexities of this will be that there's multiple agents in development. Hopefully, multiple agents will be approved, and we'll have to kind of make an effort to be able to tell one from the other with the different characteristics, and maybe some may be more active in certain disease subtypes. Certainly in diffuse large B-cell lymphoma is very active. I think as a class, you see overall responses 50 to 60%, complete remission 30 to 40% is in the relapse setting. Cytokine release syndrome requires a dose ramp up and management that will require some learning curve for physicians who are not used to taking care of this. But in general, I think most of us are getting very comfortable with the infusion reactions on this type of adverse events. There appear to be a potentially combinable class of drugs. And again, as I said, multiple products. I think distinguishing them one from the other will be important. Thank you very much.
Thank you, Paulo. Well, I invite Dr. Schuster.
Thanks, Greg. I'd like to thank everybody for attending this morning, and those that are here physically and those that are here virtually, as well as our sponsor, Morphosis, and the organizers of the meeting, Peer Review, and Penn State University for providing the continuing medical education, as well as to my colleagues for giving this great backgrounds to make these cases very easy to consider. A lot of what I say will relate to investigational agents and off-label uses. I kind of live in an off-label universe. I'm going to talk about targeting CD19 and CD20 antigens in the treatment of malignancies, as you've heard. These are some issues that I think we all need to consider when we're talking about targeting these tumor antigens. And I'm not going to answer any of these questions. I'm just going to prevent a few cases. But these are the kinds of things that should go through your mind as you're thinking about combinations, or you're designing studies, or you're thinking about the next best way to use these agents. And I'll show you in the cases that I'm going to discuss how I've done this in my clinic. You need to think about antigen expression by the tumor cells, and if they are positive, how much antigen is enough? You know, in the lab, you can get responses in cells with just double-digit antigens, but in vivo, it may be different. What if somebody's negative by flow cytometry because there's blocking? Is immunohistochemistry a better way of going? Because you can see the stain for the internal domain in the case of CD20, for example. So you've got to think about how much antigen's there, what technique you're using, and indeed, clinicians are limited by the techniques shown here. Then the mode of targeting is probably important. For example, you know, how many antigenic sites are required for activity for CAR T cells versus bispecifics versus antibody-dependent drug conjugate approaches. So you got to think about antigen density, the mode of targeting, and how you're quantitating the targets. Then the next important thing is the impact of targeting on the subsequent expression of that same antigen if you're going to target it, for example, using two different approaches. For example, you're targeting with a CD19 antibody and then a CD19-directed CAR. Can you do that? You know, will sequential targeting impair subsequent therapy? You know, will it enhance it? And there's data both ways, and it probably relates to timing. And does the type of malignant B cell or the pretreatment antigenic heterogeneity within a tumor with regard to its antigen expression impact your ability to have successful sequential targeting? So these are the kinds of things to think about, and we're happy to discuss. Now, you've heard a lot about these in the preceding two talks. These are the new tools, the new toys. We have FC enhanced antibodies that use the whole immunoglobulin structure, so these have a long half-life of weeks. And we have obinutuzumab, which is bivalent and monospecific for CD20, TafasitoMap, which also binds to CD19 molecules, and that's the most recent approval, along with lenalidomide. The bispecific antibodies we've had since 2014, blinatumomab for ALL. That's a CD19-directed bispecific antibody. It's bivalent because it binds two different antigens, CD19 and CD3. It does have activity in lymphoma, although I should mention it's not approved for lymphoma. Mosunetuzumab, which you've heard about, is bivalent. It binds to CD20 and CD3, and that's the most recently approved bispecific in the EU, where it's approved for relapsed refractory follicular lymphoma, and I think the PDUFA date is the 29th of this month in the US. And then, of course, we have the chimeric antigen receptor-modified T cells, which are basically your antibody-derived single-chain variable fragment that is joined to a chimeric receptor with an intracellular signaling portion. And these are monovalent 19-directed cells. The way I think about them is there's kind of an antibody-based therapy that's packing a T cell as the payload because it's a single-chain variable fragment derived from an antibody to CD19 that is the binding agent for these cells. And tisagenlecleucel and axicabtagene ciloleucel were approved in 2017, so it's already getting to be old news. And more recently, lisacabtagene maraleucel has been approved. All three of these target CD19. Okay, so how much antigen's enough? That's the first question that I said you need to consider. Well, I was surprised by this. If you look at the top panel, when we did the registrational trial for tisagenlecleucel, which is the CD19-directed 4-1BB co-stimulated CAR T cell, we looked at patients using immunohistochemistry and then optical imaging. And basically, if you look at the response rates, they're about the same whether you were negative for CD19 or positive for CD19. So clearly, immunohistochemistry may not, you have to have some antigen for these things to work, right? So maybe immunohistochemistry is not the best or sensitive enough technique to inform us. Yet frequently, that's what we clinicians rely on. Then, with regard to bispecifics, this was much less of a surprise, is that patients on the trials that were discussed earlier who had essentially absent or undetectable CD20 expression by immunohistochemistry did not respond to mosunetuzumab. Okay, so unlike what we saw with CAR-T, so maybe you need more antigen. I don't know the answer to any of these questions, but these are the kind of things to think about. If you look to the right at those box plots, what you'll see is that all the below the 5% cutoff, they're the ones that are negative for CD20. There's no responses because the red is progressive disease. So you've got at least a CD antigen by immunohistochemistry to respond to mosunetuzumab. You don't have to see CD19 by immunohistochemistry anyway to respond to a CAR. What does that mean? Maybe somebody can tell me afterwards. And this is just food for thought, thinking about using antibodies sequentially or simultaneously. It's all about timing. How are you blocking things? Well, we've known for a long time that all three of the clinically available CD20 antibodies, that is rituximab, the obinutuzumab, and even ofatumumab, they'll all block each other, even though the epitopes on CD20 are different. Well, how is that? They're binding different. Well, antibodies are giant. So just to give you an idea, I drew this to scale. What you see in the orange in the middle is this extracellular domain of CD19, and I'm showing you an FAB binding to it, so you get a sense of how big these antibodies are. That's just the FAB. Imagine if you have a giant antibody that's bound, what's going to happen, to other antibodies at the same time? Could they block? Well, there will be some steric hindrance, but that may not even be related to epitope overlap because there's not epitope overlap at the three CD20s I mentioned, but they still hinder each other. But it also has to do with binding affinity. If you've got an antibody that binds really tightly, it'll hold on and block the next antibody, whereas if you're treating with a weakly avid antibody, then eventually a more highly avid antibody will displace that one. So it's very complicated, is what I'm trying to say. And you need clinical trials and based on laboratory studies to determine the optimal sequencing and how to use these agents. And that's really the whole point of all this. So we have a lot to learn, although I'm impressed with the results we're already seeing. So let's move on to the cases, okay? These are all from my practice. So this is a 51-year-old woman who was referred for primary refractory mediastinal large B-cell lymphoma in November of 2019. So this is her history. She started with a cough early that year. Later, she ended up in a local emergency room where she was quite sick, hypotensive, and appearing ill. A chest CT showed a very large 10 by 8 centimeter mediastinal mass. Echocardiogram showed that she had essentially cardiac pericardial effusion with cardiac tamponade, and she was admitted to a local hospital in Delaware. Underwent a VATS procedure for diagnosis, and they created a pericardial window. The biopsy was consistent with primary mediastinal large B-cell lymphoma. The antigens are shown below under pathology studies, and she had PEs post-op. So it was a stormy course. And then, of course, they actually gave her an emergent cycle of R-CHOP before even complete baseline diagnostic imaging was done. And this is, the lower right is her PET CT scan that was done after a cycle of CHOP. So you can see, even after that one cycle, she had a lot of disease. It's all super diaphragmatic. Okay, it's just mediastinal, but bulky and causing vascular issues. There was no rearrangements of MYC or BCL2 or BCL6 using in situ hybridization with MYC IGH fusion probes and probes for the other genes. LDH was up. Other laboratory studies were really not very remarkable. These are the mutations that were seen. So interesting, beta-2 microglobulins frequently lost makes the tumor kind of invisible to the immune system, which is nice about our CAR T cells. We don't need MHC to get T cells to react against the tumor. Anyway, so this is her treatment history. She had R-CHOP ×1. They switched her to dose-adjusted R-EPOCH. She had 5 cycles. I don't know why all 5, because she had progressive disease. They gave her rice, and she had a partial response to that, and was evaluated for a study at Penn at that time. And we did a leukapheresis and actually treated her with pembrolizumab without much change. And then she went on to CAR T cells, which was the plan. We gave her radiation to the mediastinal mass, followed by bendamustine lymphodepletion and a CD19-directed CAR T cell, and she had a CR. And these are the scans after 1 cycle of R-CHOP on the top right. Bottom right is to prove to you that she was FDG negative, had a complete metabolic response. So we were all happy for about 2 months. 2 months after her CAR T cells, she showed up in the emergency room with gross hematuria and a bump in her creatinine, which had been previously normal. So radiologic imaging, and this includes an MR urogram, which is shown on the below right. She had bilaterally enlarged lobulated kidneys consistent with involvement by lymphoma. Not a pretty picture. She had no evidence of lymphoma at any other sites other than her kidneys. So this is 2 months after getting CD19-directed CAR T cell therapy, and the question is, can you use the CD19 antigen again as a target, or should you, or would you? And, or do you need additional treatment to answer that question? And I'd be very interested in the panelists to answer this if they're listening.
You can approach them and give them sequential CD19 targeting drugs. We've done that with LONCA. We've done that with Tafalen. I think you probably could have.
And Greg's shaking his head, so you must be right.
I also agree. In LONCA, I believe the testing for CD19 was required, right, on the study.
Yeah.
So that probably is the additional information we need, right? A biopsy. If anybody, the audience, you're welcome to weigh in. Okay. So anyway, so what did we do? Okay. We did biopsy her kidneys. I always like doing sequential biopsies in patients that fail immunotherapies to see what's going on and what's logical, what's not logical, even though I discussed earlier the limitations of flow cytometry, that can be blocked by antibodies that bind to the surface and block the labeled antibody, or immunohistochemistry, which is insensitive. But I do it nevertheless. And she did have CD19 still expressed by immunohistochemistry. So now blinatumomab is not approved in the United States for lymphoma, but we know from the German studies that it works. It can work, and probably should have been developed many years ago. It was approved for ALL in 2014, and we did prevail upon the sponsors to do a lymphoma development, but never happened. Anyway, she was not eligible for any of our studies at the time. They were full. I was into doing a lot of bispecific stuff at that time. She wasn't eligible, but I knew that I was getting the best responses in CAR T cell failures with the bispecific. Figured I'll do blinatumomab, which is 19-directed. So what I'm doing now is I'm giving a CD19-directed bispecific after failing a CD19-directed CAR T cell therapy. And sure enough, she went into complete remission. Very gratifying, and tolerated therapy really well. Unfortunately, we gave her 2 cycles, but she began to become really pancytopenic, and the story does not have a happy ending. The bone marrow showed she had secondary AML, presumably from one of the non-immunotherapies that she had as part of her treatment. So we were working her up for an allo, but then she got COVID, succumbed to that. So that was case 1, showing that the point there being you can target CD19, at least in this one case, again, 2 months after progression following a CD19-directed CAR T cell therapy. And I think that fits with some of the data Paula was showing us and in the biopsy she showed us as well. Here's another case. This is a case of follicular lymphoma after CD19-directed CAR T-cell therapy. I think I need to go back. This is the history. So this 58-year-old woman was referred after multiple therapies, as shown on the slide. This is kind of a long history, but basically presented with very bulky adenopathy and skin nodules, and biopsy showed what looked like a low-grade follicular lymphoma, but it was fairly proliferative and bulky when I saw her. Anyway, these are her list of therapies, which all seem reasonable. She even had an auto transplant first-line therapy, which only lasted for 5 months. And CAR T-cells, though, which she was on one of our early studies of CAR T-cells, did achieve a CR, and it lasted for a little over 2 years. Then, of course, when she progressed, she went into another study, which didn't work, and basically nothing else worked. So what would people do in this case? Colleagues and audience and
Not transformed yet?
no transformation, but she continued to express, CD19, CD20 on her tumor cells. So basically, yeah, biopsy, always biopsy, that's the additional information. I don't know that, I just showed you, at least with CAR T and T-cell the biopsy didn't matter, but I still do it. Okay. In any event, I put her on mosunetuzumab study. She was part of the study that was discussed earlier, and CD19-directed CAR failure, we gave her a CD20-directed therapy. She had CD20 on there, and you saw the long list of chemotherapeutic agents and PI3 kinase inhibitors and rituximab that she had been resistant to, so it made sense to me. In any event, she did have a complete response, and at the time I made this slide about 6 months ago, she was 39 months in CR, and she's actually still in CR, seen about 2 weeks ago in the clinic. And this is the baseline PET-CT scan prior to mosunetuzumab when she progressed after CAR, and this is after 3 cycles of mosun, and she remains in remission. And she had some expansion of her CAR T cells, as you can see the transgene levels here, in response to the bispecific, because your T cells, when they engage tumor, actually not only kill tumor, they proliferate as well. And so, not surprisingly, some of the CAR cells did. It's not required to see an elevation in these post-CAR patients for response, but it's not uncommon to see some increase. Now, this is a patient who had a CD20-directed bispecific antibody on the same famous study that was discussed by Paulo. This was a 31-year-old man. He was referred in March of 2019. Again, follicular lymphoma. I was at a meeting last night where I was hearing that follicular lymphoma is not bad. It's not a problem. It's not a problem when it's not, but there are a subset of patients that are really problematic, and this young man was one of them. His disease, you could see it grow. Even though the biopsy showed, and these were representative good whole node lymph node biopsies, showed grade 1-2 follicular lymphoma. So grade's not everything. Stage 4 disease with marrow involvement. He had some baseline bad mutations, including a p53 mutation on his next-gen sequencing. So probably explains why he didn't do well with chemotherapy-based treatments, because he's got a p53 deletion. Anyway, he was treated with R-CHOP and maintenance and R-DHAP. We're going to try to do a transplant, but he was just basically partial response and then growing. And when he got in to see me in March, he had quite a lot of disease, and we needed to treat him quickly and needed a good bridge. And if we were going to do CAR, and I couldn't think of much, so I said, well, we'll put you on study because I could take this off the shelf and get you treated in 2 weeks. And we put him on the mosun study that was discussed earlier. And he had a really nice response all over, except he had some residual nodes in his neck. We continued, but then after cycle 4, the disease in his neck began to grow. So what would you do next? And what additional information would you need? Well, we're only talking about 19 and 20, and we have a limited number of agents. So chemo, he's got a p53 mutation, not going to be a great idea. So additional information? I always biopsy these people. I don't know, and I did. And this actually will show you why I do the biopsies. If you look at the top, so I went to CD19. I gave them T-Genloclusal, CD19-directed CAR T-cell therapy. Now, I want you to look at the pre-Mosun biopsy material on the top. And what you could see by both flow cytometry and then immunohistochemistry is that this patient had CD19 and CD20 expression on his tumor cells. And the immunohistochemistry shows how strongly these cells stain for CD20, which is the golden brown immunohistochemistry. By the way, was this PET scan prior to getting CAR T, or prior to getting mosunetuzumab, the top one. So like I said, he had rapidly growing disease. After 4 cycles of mosunetuzumab, I told you everything looked like it went away on exam except the neck, and then the neck started growing, and so we scanned him. And the PET scan there, the lower PET scan, you could see there's more disease in the neck than prior to Mosun, but the rest of his body's in complete remission. So what I do, I biopsied him. And what's interesting is you could see that on the L26 stain, the CD20 stain, is completely negative. So he lost CD20. And we now know that when these patients with relapsed refractory lymphomas come to you, and this is from the a study that was recently published, the 5.5% of these patients are missing CD20 when they come to you. And we know from the study of mosunetuzumab, essentially none of those patients respond if they don't have the antigen. So yeah, I think a biopsy, if you're thinking of bispecific antibody, if these patients had prior CD20-directed therapy, I think is pretty much recommended unless it's going to put a patient's life at risk or something. And then below, as you can see here, CD19 remained expressed on these cells, although they lost CD20. Now, it's interesting, if you look right at the third square in the upper flow cytometry plot, there is a small population of CD20 negative cells on flow cytometry. There are those brown cells there, okay? And the circled ones are the CD20 positive ones. So this was a heterogeneous tumor, at the get-go. And what emerged were the clones that were negative for CD20. Anyway, we now had a CD19-directed agent, CAR T cells, gave it to him, and he went into CR. And 34 months ago, 34 months still in remission. Now that was about 6 months ago. He's still in remission. Very gratifying case. So we have all these new tools, and I hope that these cases were provocative.
Thank you so much for this very fun and really a practical presentation. So we have a couple minutes for questions and answers, and I would like to ask some of those questions which came because they're actually very interesting. And Paula, I will start from you. Any data on activity of LONCA after Tafa-Len?
I don't think that there's data out on Tafa-Len. I mean, I think there's data on LONCA post CD19 targeting drug. I think it's just you just don't see targeting CAR Ts. I would expect that if you have CD19 positive disease, you would. We're presenting an abstract this year on how it's like CAR Ts, not dependent on the level of amount or the amount of CD19 expression, in part because of how it does its work, right? It doesn't really need to have a whole lot of antigen density. So I would expect that, yes.
Yeah. And I think some of the real-world data which is being acquired about the sequencing of therapy could help us here as well, because obviously we won't be able to randomize all those patients to different studies, but we will be able to acquire from the real world. So, yeah. Steve, question specifically to you. You've been a father of CAR T cells, and you've been a father of bispecifics, and now you have those 2 children.
I'm a believer in anything that works. It doesn't matter the technique,
Can you comment on how cytokine release syndrome and neurotoxicity manifest differently after CAR T cells or bispecifics?
Okay, so most of my experience has been with mosunetuzumab post-CAR T cells, and there's no difference if they've had prior CAR T cell therapy. Haven't seen it. And the one patient I showed you with the blinatumomab, she did have neurotoxicity from the blina, which she didn't have with the CAR T cell. So, but no, I haven't noticed anything. Now, and that's just with the mosunetuzumab. And I suspect we'll see the same with epcoritamab. And glofitamab's different. Okay, that by itself actually is fairly capable of provoking cytokine release syndrome. The data didn't look that as impressive as what I've actually seen, but that, as you know, has 2 CD20 binding sites and 1 CD3 binding site, which enhances its ability to sort of cluster and kill the CD20. It's but I've not used that post-CAR, but I think there's probably Martin Hutchings has some information.
And it's also because you give it with obinutuzumab before that decreases your rates of CRS. I think we're at least on our experience with bispecific is that it's not as intense as what you see with CAR Ts. It may be a little bit more protracted.
And that gets back to the question about that I said things for consideration. They're giving these people a CD20-directed antibody, obinutuzumab, and I showed you how big those antibodies were, and they're using a CD20 times 2, but a CD20 with glofitamab, and yet glofitamab still works. And it is possible to target an antigen, I think, with more, although you could argue obinutuzumab saturating non-specific binding sites or something, I don't know. But it is possible to use more than one approach to target an antigen, and if there's any message to take from this conference, I would like that to be the message.
Yeah. Thank you. Paula, what's the experience with bispecific in double and triple hit lymphoma?
I was trying to remember the data. I think that if they were included, the activity is comparable. I don't think there's any significant differences. Patients are always high risk. There's certainly responses. I think if you look at the subgroups of the reported studies, they're sensitive to it. I don't think that a particularly more resistant group of them.
It's interesting. Yeah, there's really not much difference. Yeah. So many of the things we consider to be awful prognostically, TP53 deletion, double, triple hit. That's if you're using, chemotherapy, okay? And it's not prognostic when it comes to these external targets or immunotherapy. The T cells don't care if there's a P53 deletion. They're going to perforate that membrane and cause apoptosis. So. But the response rates look about the same regardless,
We have a list of other questions which I would encourage audience to ask directly because we're running out of time. The last one I would address here is a very short one. Is there a rationale for maintenance therapy after chemoimmunotherapy with TAFA, LEN, or bispecific antibody? I think Dr. Treblemont, the PI of the Analidomite maintenance study after chemoimmunotherapy, was here in the audience earlier. I'm not sure if she's still here, but in the development process in a PET era, PET patients who are negative by PET at the end of therapy typically do very well. So although there could be some maintenance role, I think that the study would have to be very large to actually see a significant benefit of the maintenance therapy in this setting. And several years ago, a group of experts wrote the paper Beyond R-CHOP, and the consensus was that maybe the maintenance strategies are not necessarily as attractive. Although in high-risk patients, maybe double hit and others, this would be a more promising strategy if you can select those high-risk patients. And I think we'll stop here. And again, thanks so much for your attention and joining us this early morning for breakfast and this meeting. So thank you very much. And I would like to thank our panelists.
Yep. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ENP860. This activity is supported by educational grants from Insight Corporation and MorphoSys US Incorporated.